if his back feels worse, he's demonstrating something that we call centralization, right? Do we like this? Oh, yeah, your back hurts? Yeah. Your thighs are really fine? Yeah, all right, this is good, all right? And then I'm going to ask David to do more, and he's going to do up to 10 goes. So here we go, 1, 9, okay, 10. And I say to Dave, okay, now what's happened as you do this repetition? He says, geez, you know, it's a little bit worse in my thigh when I'm done. So now with repetition of flexion, what we've seen is that his pain starts to do what? If it's not centralizing, it's peripheralizing, right? It's getting more in his thigh. We don't like that. Okay, that's not the motion that we really want to pursue. Okay, so what initially might look good or sound good, you need to repeat a few times so that you kind of figure out if it's really stable. So if David was to continue to pull his knees up to his chest, and he says, geez, my back pain's going away. My thigh pain went away, my back pain's going away. He's going home with this. This is a good thing, all right? But if he repeats this and his thigh is getting worse, what initially seemed good has proven to be irritable, right? He's getting pain that goes further down his leg. We don't like that. So now I got to do something because I can't send him out like this, right? Okay. Anybody limping through the waiting room who came in looking good is never a good advertising for the practice, right? All right. So David, I'm going to ask you to roll over onto your belly. You can do this Achilles tendons, lovely, right? Okay. So we got that done. If you wanted to do hamstrings, you can do them here while you got them. You can do quads while you got them here. Right, if you just wanted to move up the myotomes, does that feel comfortable? All right, so now, David, the first thing I want to know is when you get onto your belly, what happens to your back and leg pain? There we go, that's the plant holding on. All right, so in general, I'm going to usually be thinking that I'm likely, especially with somebody who refer pain to the leg, that I'm going to be treating them with extension to begin with. That's one of the reasons why a lot of people just don't bother doing the exam and just send people home doing press-ups. That's not the best. But you're going to catch some people that way, all right? And you're going to make some people worse that way. So David's here, and he's got, now, do you still have thigh pain? And he's going to tell me yes. And you have some back pain. All right, give me a number to your thigh pain.
4.
Okay, all right. And I've yet to meet the patient who doesn't know what that means, okay? We all kind of know what given numbers are for all that stuff is. So 4 or 10 back, in his thigh, what you got in your back?
7.
All right. Okay. So first thing, Dave, I'm going to ask you, hop up on your elbows like you're watching TV. All right. And people still know what that means. That's going to go away. Okay. And when you're up in this position, does that have any effect on your thigh or on your back?
Yeah, I don't really feel it that much in my thigh anymore.
All right. So what's David demonstrating? Centralization, right? Do we like that? Yeah. Now David might not like the fact that he still has 7 to 10 in his back. So I'm going to have to do a heavy cell job, or I'm going to really try to get this 7 to 10 pain out of his back. All right, if he can walk out from me feeling a little bit of back pain and no thigh pain, I'm going to feel, and we have a technique for him to do that, I'm going to feel pretty good about it. All right, so David, I'm going to ask you to put your hands down like you're going to do push-up. All right, now push up, all the way up, lock those elbows out if you can. And now, this isn't going to happen on a patient if they're acutely painful, right? You can imagine this. And David, what happens up here to your back pain? What happens to your thigh pain?
Thigh pain's gone, back's about 3.
All right, go on back down. Now, what's important that we do now? Right. I love it. Okay. Because if we don't repeat, we don't know if that's stable. We're going to ask David to do this at home. We want to know that it's going to work or it's not going to work before you give this to somebody. So, David, I'm going to ask you to do that 10 times. That's 9. Okay. And that's 10. And David comes back and he's kind of has, he's abolished his thigh pain and he still has a 3 or a 4 here in his back. The back didn't really get that much better over repetitions. Is that a sign that we shouldn't send him home doing this? No, why?
Because it's still central.
Yeah, exactly. So if you understand that, you say, okay, he's really kind of centralized this. He's got back pain. It feels a little bit better when he does the extension, okay? And now, depending upon how much time you have that day, you might decide whether you can make him worse again, right? Because if you can make him worse and make him better, make him worse and make him better, you're feeling really good, all right? But most of the time, I don't know that I have to be that confident, okay, or my patient to be that miserable. If I can get them better, I'm usually happy to say, okay, this is what I want you to do. Now, I'm going to keep David lying down for this, right? And I'm going to say, all right, this is what we're doing. David, I want you to try to do these 10 repetitions of these, or as many repetitions as you need to get the pain out of your thigh every hour. And that's when the patients go, what, are you crazy? Every hour? Yeah. And I say, well, you know, that's John's perfect world. We know it's not a perfect world. You're going to do this the best you can. And certainly, if you've been spending any time in the forward bent position, like in sitting, bending over, I want you to get to it relatively quickly. The sooner we can get control of this pain, the more often you don't have thigh pain, and the quicker you can actually abolish your back pain, the quicker you're going to get better. Okay? So I would send him home doing that with the first thing. So we call that, we want him to reduce this. So that's reduction of the problem. The second thing we want him to do is maintain it. All right? So all right, Dave, sit up with me here. And just sit out. Right? So if I sit here with David for about 15 or 20 minutes, okay, you know, we're here for a while. I expect I'm probably going to bring his symptoms back. This would be a good way for me to try to get that pain back in his thigh, right? If the pain returns to his thigh doing this, and even if I have him doing these press-ups, and he does the press-ups once every hour, but he spends the rest of his time here, we're probably not going to get ahead of the problem, right? So part of getting the problem isn't just teaching him what to do to try to reduce the problem. The other part of this is teaching him to kind of work on here and trying that when he sits to support his back to the best way he's capable of so that he doesn't get thigh pain, okay? So that his back pain minimizes. All right? So I'm going to send you home, David. Really, I want you to, you know, we might pull out the round Mckenzie roll. Does everybody have seen the round Mckenzie roll in some practice? It's a dark, actually a blue roll, kind of the color of my pants, okay? And you know, it sits right here along your waist, you know, in the car, in the desk chair, okay? And it's kind of like a chalk. It doesn't let you, it lets you relax, but it doesn't let you fully go into flexion, right? And there is good, you know, it doesn't make you be able to sit forever. You know, I had a guy who came into me about this time last year, and he says to me, I'm having this problem, and it's sitting, and he centralizes, and he does all this stuff. He says, and now I'm flying to Japan tomorrow. All right, the Mckenzie roll isn't up to that job, okay? It's not going to keep him from having leg pain when he flies to Japan, okay? But hopefully on the other side, he's able to kind of do his stuff, stay off below sitting. I don't know what else he can do there, okay? And it gets him managed. That's what we're going to do for Dave in the short term. If you saw a patient, do you think that you could take them through that? Yeah, it's not that hard. Okay. Now, if they all respond that way, it's even easier. Not everybody responds that way. Okay. And so I'm going to say thank you. I'm going to ask for another volunteer at some point. Okay. So that's the nice, straightforward presentation, right? Look at all these things we were talking about. Centralization. David gave us examples of centralization that were excellent, right? And peripheralization, symptoms that go further away from the midline. So we're looking for the things that centralize. We also talked about something called directional preference. Let's assume David comes in and he's got back and butt pain. And he says, yeah, you know, doing that, my butt hurts less. Doesn't really go away. Has he centralized? No, he's reduced his pain. It's not even all that peripheral of pain. But if we notice that David says, yeah, my back pain's a little bit less, my butt pain's a little bit less, and he's now able to backward bend in a way that he wasn't able to backward bend before the examination, before the treatment, we would say he's demonstrating a directional preference. He tends to get better and have better mechanical response. Maybe his straight leg raise improves, although he just had butt pain, he probably didn't have much of a straight leg raise. But something that you're doing, your asterisk signs. Do you use asterisk signs in discussion?
We use asterisk signs, or talking about comparable signs.
Comparable, yeah, okay, yeah. So the things that you use to decide whether your treatment is improving actually show improvement. That would be a directional preference, even if it didn't meet the really strict classification of centralization. Okay. The other thing about directional preference, I realized as I turned the slide, was usually there's also a comparable motion that makes the patient worse. So that's going to go back to the secret of orthopedic therapy. Okay? Usually comparable direction makes the patient worse. So what do we think is happening? And this is what I said before, is Mckenzie really, this idea that Mckenzie had that the disc was moving spurred a lot of interest in disc mechanics and a lot of research in disc mechanics. And this is what we think is happening. This is the theory. Okay? I can propose at least 2 other theories that I think are equally plausible. Okay? Because I see this on patients who probably, I see centralization on patients, and I see improvement in patients who probably don't have discs that are all that mobile from a nuclear standpoint. Okay, so when does the disc start to degenerate? Well, around 17. So, good news, guys? Yeah. All right. You're all starting to desiccate a little bit. All right. You're all starting to kind of dry out. You probably all have a few little annular fissures here and there. But those of you who are on the 45 and younger side probably still have relatively mobile nuclear material. All right. So you can picture the annular fibers, right? What is the disc? The disc is actually a really specialized ligament, right? It holds one bone to another bone. That's what ligaments do. Right? But interestingly, the disc not just holds one bone to the other and keeps us tight in tension, right? You know, so any ligament, do Vaga stress test, Vera stress testing, where I'm testing whether that ligament can be tensilely intact. When I try to strain it, does it stay, keep the bones in place? The specialization of the disc is that it even tenses in compression, right? So when we compress the disc, the nuclear material bulges out against that Chinese handcuff material that is woven together, and when it bulges out, it actually stiffens the ligament. So when we compress, we don't actually fall down, right? The ligament kind of bulges out and provides stiffness, passive stiffness to the system. So that nuclear material is really important, that has that ability to push out against the walls. Now, if the walls start to crack, right, and that's where the walls begin to crack. They begin to crack on the nuclear end of the disc, right? Not on the annular wall side of the disc, but on the nuclear wall side of the disc. Start to crack, and we start to get that nuclear material that starts to work its way out, like a little foot, like a little pod. You know, I always have this picture of the amoeba that I first learned about. You know, you have this little pod that's kind of sticking out, and it starts to get in there, and that might be some of the stiffness that you and I get every so often when we get out of the car. Maybe you guys aren't getting it yet, but I know I get it, and kind of you got to do a little bit of this, and maybe I'm moving that nuclear material, if it's still even around for me, okay, a little bit more to the center. And then if the nuclear material works its way all the way out, okay, back, I want back.
You gotta push the air up.
Oh, okay, hang on, I see it. Hey, it's just like PowerPoint. Okay. No? There we go. I'll stand over here. Then if the nuclear material makes its way out, right, we can get a herniated disc. But long before a disc herniates, and we know that you can have a herniated disc and not have any nerve root involvement, right? We're good on this? All right? We know that we can don't have to have this free protrusion to have changes in our disc mechanics. So that's one theory behind the Mckenzie approach, and that is that we're going to apply forces, right? So let's see. That's the posterior wall, right? The line of being shaped, it's always the concave portion that's posterior. Okay. The idea with the central symmetrical is that you're putting pressure right on the posterior wall of the disc. And which way is the nuclear material going to move? Anterior. Well, just like the toothpaste in the tube, right? It's moving away from the pressure. It's going to move anteriorly. And we're going to look at asymmetric technique when we look at unilateral asymmetrical, folks. And let's say that pressure's a little more out to the side. It might be that we have to get our pressures a little more out to the side in order to get centralization, right? And maybe it's even further out to the side. We've got to work out here. We've got to work in flexion to get centralization. Okay? So that's a mechanical thought. But I think that there are equally compelling arguments to the idea that one of the things that Mckenzie does is says, not Mckenzie, those of us who are practicing this, says, oh, that hurts? Let's try that 10 more times. Right? Now think about that as a patient. Right? Did you not hear me the first time? I told you it hurt. Okay? Why are you saying I should do that again? And if you think about the
the fear avoidance model, okay, where we start to talk about, how come patients get into this place where they kind of start to have problems, can't get out of the way, and they have pain that starts to take over their activities. One of the fear avoidance model talks about people over here who are confronters and the people over here who are avoiders, right? The people who avoid pain. Oh, that hurts, it must be bad. That hurts, it must be bad. Oh, that hurts, it must be bad. And you know that there are people who are, you think, oh, come on, put up a little pain, do something there. And you know that there are people over here on the other extreme who say, oh, that hurts, I'm still going to do it. Still going to do it. And you kind of can figure out where you fall on that scheme. And it isn't always the same, right? I mean, if it's something that you want to do that day, you might very well put up a little bit of pain. You woke up and your knee was a little tweaked, but there was a soccer game that you really want to play, and you say, I'm going to be okay, right? I'm going to be fine. All right. There's all those things, and there's that model of, do we start to really avoid things? I think one of the things that I notice when I work with my patients get that quizzical look, like, is he a mad scientist? What the hell is he doing? And you say, no, follow me. And if, as they repeat something, they realize they're not getting worse, we've just stripped away some of that avoidance that they've built up. And they can start to confront it in a very mechanical, controlled way. So that might be one of the mechanisms at work. And it doesn't mean that, it doesn't even deny the first mechanism here of the disc, but it might be another part of that mechanism. And then certainly a third mechanism is both peripheral sensitization. Okay, this idea that the nerve endings around the annular fiber become sensitized to the situation that they're in. And just like if you've ever done deep friction massage to yourself, like your forearms hurt and you get in there and you kind of poke at it a little bit more. Okay, or when you were a kid, you remember the loose tooth, right? It was there, you kind of feel it hurt and kind of, and you kind of work that thing until you went numb, right? Do we have peripheral sensitization at the level of the annular fibers that we're actually working on with this? And that's certainly a reasonable other consideration going on here. And again, none of these things negate one another. They just should be things that we're thinking about as well. So this is the current disc theory, right? The theory of peripheral sensitization at the disc. Paul Menke is a PT working on this right now and doing pretty interesting stuff. But he always has the most boring headings for his papers, so you'll probably never read them. Okay. So he's doing a lot of work on the peripheral sensitization at the disc, and then we have lots of people, and I think the person who I go to read the most is a guy named Stephen George at the University of Florida, who is working a lot on the idea of the fear avoidance model and how it pertains to us as therapists. Like, you can go read this thing and you think, yeah, but I'm not a social worker and I'm not going to be a psychologist. And he kind of takes this stuff and says, well, here's the things that we can do. This is how we do graded exposure. This is how we do graded activities with people and graded exercise. So we have David here, and because he's a plant, it would seem, he responded perfectly to his asymmetric symptoms, and with just plain old extension, he got better, and everything was wonderful, and he's going to write me a thank you card from Aruba when he gets there, right? That doesn't happen so much, okay? You usually have to fiddle with this a little bit more. Right? So it would be nice if you had that patient who came in and everybody responded that way, you'd be able to do it. But you oftentimes have to fiddle more, and that's how you figure out, you've got to figure out which way we're going with these forces. So I need somebody else with make-believe back pain. Come on, come on. Oh, everybody's looking down. David's shoes are free. Anybody else can see their shoes? Okay, yeah, because everybody's looking down at their shoes. Come on, make-believe back pain, come on. All right, what's your name?
Erin.
Hi, Erin. I'm John. All right. So Erin's got the same back pain and leg pain that David came in with. And Erin's saying, geez, I got back pain, I got thigh pain. Maybe she has a little more thigh pain. Maybe it's there more often. Okay. And now, Erin, when you backward bend, come on, backward bend with me. Ooh, say ooh, ooh. Okay. And it goes down her right leg. Okay. All right. So it's getting worse in her right leg when she backward bends. We say, Erin, okay, bend forward. And Erin bends forward, and she actually deviates off to the right. Come on, go to the right with me. Ah, that hurts. Okay, going down the right leg. Yeah, okay, so let's do backward, forward, that's not good. Let's try going away. Erin goes this way and she says, meh, okay. Doesn't really make her feel worse, doesn't really make her feel better. Maybe I'll come back to the lower one. And Erin, come on, go this way. Ah, that gives her pain down her leg, right? So we don't really have much of a pattern here, right? Erin's pain is getting worse whether we compress it, and it gets worse when we compress it to the right or compress it backward. It's getting worse when we stretch it. We go out this way, again, meh, doesn't really change. It's not like she goes, ah, my leg pain's gone. She just says, no, it doesn't really make it worse. So in standing here right now, we can try some repetition, right? We can say, okay. So you're standing here, and let's do repeated extension and standing, and we could do a whole bunch and say, okay, come on, Erin, go with me. And Erin's saying, it's getting worse as it's getting worse down my leg, and when I stop, it's worse, right? That's time to stop. That's time to stop. You've proven your point. Don't keep doing that, right? You can try repeated forward flexion and say, okay, Erin, go forward. And again, she's telling me it's getting worse, it's getting worse, it's getting worse. Okay, and it's worse down her leg. All right, so come on, you can stop now. Now, do you have any other problems before I, okay, yeah, all right. So, and now that ain't working, right? What am I getting? I'm getting worsening peripheral symptoms. That is not the pursuit, that's not something I want to keep pursuing. Okay? I can try side gliding her now to the right. Okay, and she can do this. Okay, yeah, come on. Spread those feet, okay. And she's going to go this way. And with repeated side gliding, she's still getting worse down the leg. I've got to change the context that we're doing this in. We're going to do it in line, right? So come on, Erin, come on, lie down here. Okay. And we try flexing Erin up, and again, her thigh pain is getting worse. We come over onto your belly, Erin, okay? And Erin does 10, 15 press-ups, and her thigh pain keeps getting pain down into her right thigh. It's not getting better, it's getting worse. All right. So now we're going to side glide Erin. Okay. We've pursued extension. Okay. One of the things I might do with Erin if she was doing extension, I might say, okay, let me see if I put some pressure on Erin while she goes up. Go ahead, Erin. Okay. And now up on your hand like a cobra. Okay. I work in Northampton, so if I say cobra, everybody knows what to do. Okay. And got pressure down in here, and even with me applying external force, she's still getting pain down her leg. Go ahead back now. I know I'm going to have to kind of side glide her someplace to see if I can centralize this. So what I'm going to do is I'm going to pick Erin. I'm just going to pick your hips up and I'm going to pull them towards me. Okay, don't help. All right, good. All right. So here we are. We've just pulled Erin to the side, and I'm going to pull her legs this way. All right. So what have I just done? I've pulled her hips to the left, and if you had to describe this, if you go to write the note, you say, what the heck did I just do? I got to write the note. Which direction did I just side bend her in? Right, yeah. Why? Because we always name it from the top. Right? So I came home from my first Mckenzie course, and for 6 months, pushed people the wrong way. Okay. Maybe I even got it right because I'm a little dyslexic when I walk around on the table. Anyhow, okay. But what you're essentially doing is, if you have right-sided asymmetric pain, you're moving the hips to the left, which is right side bending. So the best thing that happened for me is I stopped trying to think that way, and I just said, the pain's here. I got to close down that side. Okay, because when I start to try to think it, I've gotten better about talking about it. When I start to try to think about it, I go, blah, blah, blah. All right. So pain here, down here. I got to close down the side that the pain's on, and that's what I've done here. Now, Erin, when I do that, do I make your leg any worse? And she says, no, it's no worse. Is it any better? No, it's no better. Okay, now let's go through the extension progression again. Okay, so Erin's going to get up on her elbows, okay, and we're going to say, okay. So do we call this the? See, I jump. This is the extension progression. You put somebody in line, you see how they feel. Then you put somebody on their elbows, you see how they feel. Then you put somebody up on hands, cobra position, okay, all the way up, and we see how it feels. And Erin says, geez, I can go all the way up here and it doesn't hurt down the leg. All right, so now the question is does that mean that her leg pain gets better? Is that a question?
Yeah, how is it different than extension and right side bending and standing? Does it increase her pain?
Okay, yeah, come on, great. So what's your name?
Ryan.
Ryan. Ryan?
Yeah.
Okay. So that's a great question. Ryan's question was, well, if that works, how come this wasn't working? And the best answer I can give you is I don't know. Okay? But the thought is this, and that is that you've got this person who's under compression, right? I mean, if nuclear material's there, it's bulging a little bit more because you got body weight down on it, okay? And it's a little like, what I picture is I'm squeezing the head of a horse out the barn door, right? It's kind of out there and there's no way for me to capture it. And when I get somebody to lie down, I take some of that nuclear, that outward pressure from the nucleus off. I'm still going to get some pressure from motion, but I'm not going to have the same type of compressive force from standing. So that's my understanding. So the answer is it only works if it works here. I mean, I've had patients who I cycle out here, ain't happening. Okay, this isn't getting better either. I'm peripheralizing. Okay, and I can picture, like in that patient, you know, when I talk about this now, I've been so inculcated to say, don't think like about pathoanatomy, right? You're not supposed to think about pathoanatomy because we can't possibly know what's going on in there. And yet, the only way I can think about people is really if I think about what's going on in there, right? And I know that there are patients who probably have bony overgrowth in this area, and all of my nuclear fiddling isn't doing much of anything. And certainly, as my patients get older, I expect that this is going to make most of them worse. Okay, because if you've got a little bit of a lateral recess stenosis or a central canal stenosis, you're just jamming things up. You've got 2 pounds of bologna and a 1 pound sack in this position, and it's likely that you're going to get pain that goes down the line. Right. So this is our one position to get into, right? So we might side glide Erin and take her through the progression. Okay. If we get centralization there, we're great. If it's not there, I'm thinking, I got another patient coming. Okay, I got to figure out something to do with Erin. I got to get her out of here so that she's feeling better. I don't want to send her out when all I've done was made her worse. Okay, I've got one more trick up my sleeve before I start mobilizing her, and that's to ask Erin to come over onto her back. Okay. So again, Erin has back and right-sided pain, and in extension, we were able to get her over here. But if I flex her, I'll be able to get really far laterally where I can compress it. So I'm going to be on Erin's right side because I want her to come this way. And hang on a second, Erin. I just got to get my... I just got a new cardon table, and it has all the switches on the tubes. So like right here, if I put my foot on the top tube, it goes up. If I put my foot under the top tube, it goes down. On either side of the heads, oh man, I move patients all the time just because I can. It's really cool. All right, so we're going to bend your knees here. All right, so I'm checking in with Erin here. And now, I could go here right away when I have her on her back, right? I didn't need to go to the belly and have her do extension and have her then go to side gliding. I could have checked this right away. By convention, I usually don't, okay? But I could absolutely have done that. Right. So here we are, we've got back and we still have right thigh pain. And I'm going to take Erin up to here. I'm going to flex her. And we're going to come down in here. And I'm just going to see if I can bring Erin into this position. I got you, you're not going to go on. Okay? And come on through here. Right? So can I start to get this? And if Erin goes, oh, okay, just keep me here for a little while. This is the 5:30 on Friday treatment. Matter of fact, somebody comes in with back and leg pain 5:30 on Friday. I don't do everything else. This is what we do. Okay. All right. We want to try to get this better as quick as we can. All right. And we work our way backwards then from there. So we've got this, and Erin says, yeah, this makes my thigh feel better. Now, she might not be any better when she gets up, but if this makes her thigh feel better, this is the way we're going to start. So this is the far lateral portion, far lateral asymmetric. Right? So we started with central symmetrical treatment with extension. Then we went to asymmetrical treatment with extension and side gliding. Okay, and then we went to flexion rotation. Actually, the Word document, do these guys have that?
No,
Well,
but I can print that.
Yeah, or if you
It's
get
on
in,
Blackboard. There's a Word document in Blackboard. It's John Sullivan's
Handout.
Word document or whatever.
Yeah.
What's it called?
Handout.
it actually,
John's handout. It's in Blackboard, yeah.
yeah, so it's something other than just the PowerPoint, okay?
It's a Word file.
And it just kind of takes you through this idea of that idea of, okay, I'm trying to get the central back portion of the disc, I'm trying to get the posterior lateral portion of the disc, and this flexion rotation is trying to get the most lateral portion of the disc.
Okay, we're going through, 90 degrees of an oblong, make it a circle, what the heck, right? It doesn't matter if you're not. Okay, we're going through that 90 degree arc with that attempt to see if we get centralization. All right. So what I wanted to do at this point was have everybody try extension, right? Extension with side gliding, and that means that your partner has to side glide you and move your feet, okay? And then flexion rotation. Then we'll talk a little bit about manual technique and come back together, talk a little bit about manual technique, and then start to apply manual technique to this stuff. All right, because the thing is if you're having somebody who's starting to respond, sometimes they stall and they need a little thump, okay? And that's where the manual technique comes in. All right. So questions before we start to break with one another. All right, so what I'm going to ask you to do first, what I'm going to ask you to do first, everybody's going to be partnered, right? Lay flat on your belly, get up on your elbows, do 10 repeated extensions.